welcome Carolyn Joseph today. Carolyn is a pelvic physiotherapist. She practices out of Live Well in Baden and out of A Body in Motion on Victoria Street. So I'm going to hand it over to Carolyn to just explain to us a little bit about what a pelvic physiotherapist does and what drew her into this field.
Okay, well, yeah, thank you for inviting me, Shelley. I always love getting to talk with you, and I always add things from your practice and the yoga into sort of my tool set too. Every time there seems to be something I really glean from that. But yeah, I've been practicing as a pelvic physiotherapist for about 5 years now, and before that, I was working in orthopedics for about 5 years. And it was after I had my second daughter that I started to think about pelvic health. And with her, it was a little bit more of a difficult delivery, and I really was unprepared for that afterwards. In a sense, I realized I have no idea what's going on with my pelvic floor, what recovery looks like. And I thought, this is something I should know, given that I'm working in a field of muscles and recoveries. And so I started seeking out at that point the courses for pelvic physiotherapists, and it just so happened it was around that time we started being able to take these courses in Canada for physios instead of having to travel internationally. So that really got rid of a big barrier. And within that year, I had taken the first 2 courses, and I switched my practice right over to just working in pelvic health. And what's not only drawn me to it, but really kept me here is that it's such a rewarding field to work in, because you can make such a big difference, a big change in people's lives, often in a really small amount of time. Not always, there's no guarantees with anything that way, but I'll see people who have symptoms that are all encompassing, and within a couple of appointments, just with a little bit of education or a little tweak on how something's happening and a realization, they can go really turn the corner on something that may be plaguing them for years. So very rewarding, I'd have to say. Mm-hmm.
I should say Carolyn's actually my pelvic physiotherapist, and not only did she give me a lot of information about my own pelvic health, but also I actually had this chronic rib condition for like years and years, and it was just a few appointments between the two of us, and everything is so interconnected in our body. So just a few appointments with Carolyn and I don't have my rib issue anymore. And honestly, that was a chronic condition for me for like years. I'd say at least 4 years before I saw you. And yes, you healed me. So thank you.
Well, great to hear. So again, it's so rewarding to always hear those stories.
Yeah. So what you might want to share with people, because I was a little bit unprepared for what an assessment looks like. Someone had kind of mentioned it's maybe more intensive than you think. I think I went in and thought like you were just gonna like feel around on my outer abdomen, and so yeah, I mean it is a very thorough examination, but thankfully it is, because I think that really gets to the root of where a lot of us are having issues. So do you want to share kind of what a pelvic assessment looks like with you?
Yeah, for sure. And I think it's a question that a lot of people have, and we often don't realize this as practitioners, because you get into the routine of it every day. It's so normal to me, but I can count many people who have come into the office and they say, I was referred by my doctor, or here's my referral, and I'll look at the referral and I'll realize it was written a year ago, and they'll kind of look at their toes and they're like, you know what, I didn't feel I necessarily was comfortable coming in. And thankfully, almost everybody, when they leave, they say, oh my goodness, that was so much more comfortable than I thought, and I wish I did this a year ago. But it's a common thing that way. So it always takes place in a private office, usually in a physiotherapy clinic, because that's where I work out of, so that'll always be the case. And the first probably half of the assessment time is spent just getting a history, talking. So we're sitting, comfortably in a room. I mean, nowadays it's comfortably distanced in a room. We have a chance to kind of go through the person's story, and that's often what I start with. I just say, tell me what it is that I can help you with, and then I'll ask you more questions from there. And then I have my whole list of sort of things that they, you might not necessarily realize are related, and I just, go through those after to check off. I know you came in for your bladder, but has your tailbone bother you? Has your low back bothered you? And we can kind of put those pieces together too. But that usually takes up the first half of our time, because there's a lot to go through, history of any sort of gynecological history, any sort of injuries that you might have had. And usually after that, you can get a really good idea of what's going on with somebody and even what the prognosis will probably be. However, we still do the whole second half, which is the hands-on piece. And that's broken really into two pieces. So the first one is the external examination. So that's where everyone's wearing all their clothes very comfortably. And I'm getting them doing things that would be similar to what you'd see when you go in for orthopedic physiotherapy for like a hip or an ankle. And they're standing or sitting, bending, twisting. We're checking the strength of muscles. We're checking their posture alignment. And we're checking the flexibility or anything that might be kind of out of the range of normal, so that we can address that, especially if it's a contributing factor that way. The last little bit is the internal assessment, and that's what always worries everybody because you don't know what to expect. It's much less invasive than getting a pap test done.
Yes, it is.
And it's much less uncomfortable, or less uncomfortable is what I'm trying to say as well too.
I didn't find it uncomfortable physically at all. It wasn't uncomfortable physically. I just wasn't realizing when I went in that there would be an internal. But once I wrapped my head around it, I was thankful, because I think, yes, you have to kind of feel what's going on inside to kind of know what's obviously fully going on in the body. Yeah.
And most people are usually very grateful to know that information too, because I really can't tell by looking at somebody whether their pelvic floor muscles are not working at all or working with totally full strength. And I certainly can't tell if they're doing a Kegel properly or incorrectly unless I actually have done that internal assessment. So people are usually really happy to find out what exactly their strength is at. And I always tell them that right after I explain how we grade the strength of the pelvic floor muscles on a 5-point scale. 0 is no strength, 5 is full strength. And I say, you sit at a 2 out of 5. That means your muscles come together, but they don't lift up. That would be that next level of strength. So it's very empowering, I think, for people to know where they sit. And also from there, I can always say, and I would expect you can get up to, and almost always it's a 5 out of 5 strength. And that's really helpful for people to know too. So it really only takes about 2 minutes to go through that internal part of the assessment. But the other important thing we're always checking at that point too is if there's any abnormalities that need addressing to see with a doctor or a specialist. And I can certainly make that referral and recognize too typically when that's needed, either as a concurrent thing or whether that really isn't needed at this point. And also to check for a pelvic organ prolapse, which again, you can't see unless you're doing that internal assessment. So whether the bladder, the uterus, or the rectum might be protruding downward, even just a little bit. Most people wouldn't feel the start of a prolapse. So to be able to know, look, this is what's going on and what it's, preventable if we kind of take these steps.
Mm-hmm. Mm-hmm. So that's great. So that's kind of getting us into what areas a pelvic physiotherapist can help us with. And maybe you can elaborate on that a little bit. Like what are some case studies? What are some things that you see most common, or maybe things that are a little bit rare that we wouldn't expect that a pelvic physiotherapist would discover?
Okay. Well, I see people from all over the spectrum in terms of ages, which is maybe not what people would expect. A lot of times we think of it as like a pregnancy related thing or an age related thing, but I've seen people from teenagers right up until clients in their 90s. So it's certainly a broad age range of people that can be helped by pelvic physiotherapy. The bladder is probably the thing we're best known for, right? If you have some leaking or if you have urgency, if you're going to the washroom all the time, the people who say, I have a small bladder, people say you should see a pelvic physiotherapist. So that's probably our most, our claim to fame right now. But I'll see people even with the simple symptom of, I just realized I can't stop going pee mid-flow and I think I should be able to. And it's true, you should. So we usually have something to work on there, whether it's strength or sometimes it's just coordination. So probably anything bladder would be an appropriate pelvic physio thing. And likewise, anything bowels too. And that's bowels can be something you don't think of so much for a pelvic physiotherapist. Constipation can have quite an effect on a lot of the systems, or leaking from the bowel too. So people who do have some fecal leakage, that's a really difficult symptom because we don't talk about it so much. It's very embarrassing, and it often robs people of a sense of dignity, right? And so that's a really important symptom that can be dealt with in the pelvic physio world too. Tailbone pain, often to assess tailbone pain, the coccyx, I'll do a rectal exam, which again, you might not think of as that part of a pelvic physio scope, but absolutely. And it's something that, depending on how the tailbone might be out of place, you might have to access that internally. So that's something that you would need someone who does those internal exams for as well.
That's interesting. That's really interesting. I actually know someone who has had tailbone issues for quite a time. So I'm going to send her your way. I never kind of put those two things together, but that's interesting. So then what are things that we should be doing? And let's kind of break it down into two different decades combined. So what should we be doing in our 20s and 30s? And I'm separating that just because those are kind of basically our childbirthing years as women. And I guess we can talk about it in terms of men too. Let's not leave them out, but what we should be doing in our 20s and 30s. And then what should we be doing in our 40s, 50s, 60s?
Okay. Yeah, no, I think that's a good way to break things up too, because that is often, like you say, the childbearing years, and then or even just the younger years where all the rest of our muscles are quite strong, and then the older years as things start to change and hormonal change start. And I think that's probably one of the most important questions too, is what can we do to prevent things? Because it's so much easier to prevent things than to reactively try to deal with them. So I'd say in 20s and 30s, one of the first things that comes to mind would be anything that's been kind of a lifelong or chronic thing. People will say, I've always noticed since I was a kid that I've had a small bladder, or people say, I've always noticed that I've had pain with intercourse ever since I was sexually active. And those would be things that you certainly, anything that's been going on forever, that'd be a good time to fix it up, because typically things don't, if they've been there for a while, are probably not going to get better as you get into that second age group that you were talking about. So to get anything like that addressed through a doctor or through a pelvic physio would be good. After that, I think the biggest thing in that age range would be knowledge, to know what is normal and what is a sign of things that aren't quite going right. So in the past, we many times women kind of accepted it to be normal to have leaking after having a child, or we accept it's normal that I go pee all the time if I'm pregnant. But to know what normal is. So some of the important normals that I'd say to keep an eye on are that how often are we going to the bathroom? It should be about once every 3 hours. And overnight, 0 to 1 times, depending. If you're younger, probably closer to the 0. As we get more to that second age group, 40s to 60s, 1 time would be considered okay or normal. That we shouldn't be leaking, that we shouldn't have any pain with intercourse or pain with going to the washroom, and that we shouldn't be having any pelvic pressure, that feeling like my insides are just falling down on me. So being aware of what's normal is probably, or getting educated on it, is one of the big things for that. If you do have any pregnancies, deliveries, then getting everything checked out and kind of back to your normal after that would be an important thing. A lot of times we just leave that, especially if they're very mild symptoms or even no symptoms. It's still helpful to get an assessment, because I find most people after a pregnancy have lost quite a bit of pelvic floor strength.
Yes. So, I mean, I'm so grateful that your field is gaining, like people are becoming aware of your field, because so my son's 16, almost 17 now, and I had so many issues after I had him that, never really, it was just kind of like, oh, that's, what happens after pregnancy. But, I wish someone would have been there to help me, because I think I would have recuperated a lot a lot faster. And it did have to do a lot with weakness in my pelvic. I had a C-section, so I had lots of issues, and just kind of like not a birth that went as planned. I was supposed to have the midwife with like the natural birth, and yes, that was not my experience throughout the whole thing. So I think into it, like when things don't go as planned, there's like a little bit of shame or guilt or whatever that comes out after that happens. And then it's like, I don't know, I kind of was afraid to ask for help with what was kind of going on. And I've heard that that's really a common thing. You think you're, well, I just have to solve this or figure it out, or it just will eventually go away. And I wish there would have been more awareness that could have helped me kind of resolve those issues more quickly. So I'm very grateful that that your field is again gaining more prominence around, so you can help those new moms out.
Yeah. I think it's very common too that we often will have a plan, or plan A, and when it doesn't go that way, and it never will, something won't go exactly that way, whether it was the birth plan, whether it was breastfeeding afterwards, whether it was recovery with symptoms, when that didn't look, textbook the way it looks on a baby story or something. There's kind of a little bit of a grieving for the loss of that picture that people have to go through in different degrees, but that's certainly part of sometimes of recovery, that there's things we don't expect.
Right. So let's get into now our 40s, 50s, and 60s. So I'm 48 now. So I'm kind of in the middle of all this right now. So what are things that I can be doing now to support pelvic resiliency, pelvic stability? What are some things I can be doing at this point?
Probably the most, the first thing that comes to mind would be to make sure that you're well aware of how to use your pelvic floor muscles. So can you find those Kegel muscles, which is just sort of a general term for the group of different muscles in the pelvis there? Can you use them effectively? Are they doing their job to support up the pelvic organs? So making sure that you know how to properly do that, and then checking in with those muscles as needed would be an important one. Another really important thing as we get through that 40s, 50s is keeping a good strength in general for our bodies, because we do tend to lose a little bit of flexibility, a little bit of strength. And in that case, when we're doing all these tasks that we still are doing in our active lives, such as lifting and bending, it's now putting more strain through our pelvic floor, because if our legs aren't strong enough, if our arms aren't strong enough, if we're not flexible to bend all the way down, then those lifting mechanics or that weakness can present as extra intra-abdominal pressure that pushes down on the pelvic floor. So the external piece really is important for all of that too. The more related to that decade or decades would be going through menopause, and there's a lot of hormonal changes that happen then, and that can present in very different ways for people. So being aware again of what those normals are and checking in if something is starting to show a red flag. Things that change are the muscles do tend to become a little weaker. The tissue becomes less elastic in our pelvic floor. So potentially before we were relying on a bit of that elastic hammock to hold things up, and now that weakness might become a little more apparent afterwards. Or tissue often becomes more fragile or dry, and that can sometimes lead to pain that was never there before, or even some tearing or like I said, dryness that way, and things that are quite treatable. Sometimes there's, we'll often work on that a lot if there's some tissue restriction or even scar tissue from a pelvic therapy side, sometimes concurrently with the doctor for maybe a prescription for vaginal estrogen if that's needed. So monitoring again for any of those red flags that could pop up that way is certainly what I'd recommend.
That's great. So kind of leading on from that, or moving on from that, what are maybe two things we can do in our day that kind of work to, keep that resiliency in the pelvic floor, or, create that stability for ourselves in our pelvic floor muscles?
One of the first things that comes to mind with that is related to stress management. Actually, they've shown in studies that the pelvic floor muscles are one of the first groups to respond to stress, just like we hold it in our shoulders. People will often hold it in their pelvic floors as well. So being aware of that connection is one of the first things. And what tends to tie in with that when we are stressed out, or if we just even have physical stress like pain, discomfort anywhere, is we tend to do a lot of chest breathing. And that puts a big effect on the pelvic floor. And I go through with all my clients, you remember probably going through, is what a proper breathing mechanic should look like. So when we're just sitting restfully or lying down, we shouldn't see any chest excursion happening as you're breathing. You should just see your belly gently kind of in and out. So the idea of sucking and holding everything in is counterproductive for our pelvic floor. If you can imagine, every time you're breathing in and your belly's kind of ballooning out because your diaphragm's coming down, all those pelvic floor organs and muscles underneath, they're almost getting a little bit of a massage. Instead of staying stiff, staying tight and tense when they're all up like that shoulder. So being aware of our breathing mechanics, doing quiet diaphragm breathing through the day actually can go a long way to ward off many symptoms from tension, pain, bladder urgency, just to even breathe better through the bowels.
Right, and bringing us into a little bit more balance, that parasympathetic nervous system activation with that breath kind of brings your stress levels down as well. Absolutely. So Now, the one thing I learned from you, both when I met with you and then when you came into the studio and did a little talk for us. So I have done a little bit of pelvic health training through yoga. So you really helped me with what we call the pelvic breath here. So I had often cued the, as we inhale, that softening of the bottom of the bowl to let it slide out through the hips. But I struggled for cues with the exhale and that contraction of the pelvic bowl. And you really gave a great cue when you were in here. So it's like, where does that stop? When we're doing the contraction up, you had said the elevator's doors close and go up 4 floors. And that was really helpful for me, even in my own practice, because I think when I was contracting, I'm like, I always had the cue of drawing up towards your throat. And it's like, where do I stop? I didn't get that final nice contraction at the end of it, which going up 4 floors as you think about that contraction going up. So you really helped me with that cue in terms of how I engage my pelvic floor with that contraction and the balance between bringing a little bit of resiliency and softness. So with the inhale, kind of softening the bowl, that's that opposite of the contraction to just keep, I always think of resiliency, pelvic resiliency is what I call it, that movement of making it, I think in my mind, stretchy, and then also the contraction to bring a little bit of stability. So do you have anything further to add to that in terms of taking the breath into the pelvic floor is what I call it, but how that pelvic breathing, any cues for us with that?
Yeah, I think you describe it really well. From a function, when I'm talking just about function, because sometimes that works better for people, I'll say as you breathe in, you're letting go as if you're about to go pee. The more extreme version of that would be you're pushing out pee. So as you're breathing in, pushing out pee. I don't ever want people to bear down or push down, but if they're just struggling to figure out which way do you mean, sometimes that extreme can help, and then we kind of back that up. Breathing in like you're letting go, about to go pee or about to pass gas. Those are the functional things that we do. And then when I exhale, I'm pulling up like I'm trying to stop going pee. Although it's that 3-dimensional idea you're talking about, I say it's going all the way up almost towards your belly button, towards the left, as you breathe back out again. And you're right, a lot of times that's what I'll find when we're doing that internal assessment. It's not too common that people are doing it totally wrong. Usually, sometimes we can get a little backwards in how we do it, but most of the time we're used to that idea of lifting up, supporting up, but it's a matter sometimes of how effectively are you doing it. So if you got an analogy of 4 floors of an elevator, a lot of times I'll find people only realize about 1 or 2 floors, don't realize that actually there's more range to do with that. And you can spend a lot of time strengthening only half the range of muscles, and you won't ever get that support for the deeper pelvic organs, at least not nearly as effectively.
Yeah, that's great. And another cue I think that you gave, I believe it was you that gave me this, that often when we're sitting and we move to stand up, we inhale. And when you do that, the bottom of the pelvic bowl just kind of is free to fall or free to hang out there. But if we can remind ourselves of the cue as we exhale, a little bit of engagement of the pelvic floor to transition from seated to standing. So I have taken that a lot into my yoga classes as I'm guiding the yoga classes. So as we're transitioning into something where it would feel natural to just let the pelvic bowl kind of hang out there, sometimes it's a better cue to kind of contract that, create stability in your pelvic area before we move. So I think maybe you can talk a little bit to that just in terms of movement in our daily lives, like how we can kind of address what we're doing with the pelvic bowl. Not that we have to think every movement, what am I doing with my pelvic bowl? But, there's some cues we can kind of remember and train ourselves in our day with that. So do you want to speak to that a little bit? Maybe give us some tips on that?
One of the coin phrases that we'll often use is blow before you go. So before you, in that case, get up from sitting down, you want to blow or exhale.
Yeah.
That would be extreme. Getting up from sitting down is not something that most people who maybe aren't having a lot of symptoms need to do the whole blowing out your candles sort of idea.
Right.
But if you were sore, if you were weak, if you were recovering from something and it was a more major endeavor to do that, absolutely you'd want to do it that extreme so that you can remind your body not to hold your breath, not to brace, and be bearing down. But as just sort of on a low grade level to practice that, just to retrain some of that reflex for getting up from sitting down, from lifting is a really important one. That's where we often will say that blow before you go, before you lift. You want to, and right through the lift too, to be lifting or exhaling that way.
Right.
The other coin phrase I'll say is exhale with effort. So if we think of that more with the with weightlifting too, or any sort of like body resistance, when you're actually applying the effort. So if I'm lifting up the barbell or curling up, that's where you would be exhaling or blowing, so you're not creating that intra-abdominal pressure.
Yeah, I think that'd have to be a little bit of a retrain for some of us, because I think our natural inclination is to inhale as we do those kind of things. But yeah, that exhale. Yeah, that's great.
But if you're not exhaling, the pressure is not coming out, you're still generating this intra-abdominal pressure. So it's probably trying to go out through the bottom, which is contributing to pelvic organ pressure, or if you have a prolapse, putting some extra strain through that weakened area.
Right. Yeah. I just want to thank you again for all the information you shared with us today. Do you have anything further you want to add, Carolyn, today?
You know what, I would, the one question you had asked a little earlier about just, you said any case studies or things that popped to mind, and I didn't get a chance to say one of the stories, I guess it's more of a story of a client that always sticks out to me. It was a lovely lady, and she was about 83 years old, and she had come in and she kept looking at me and saying, Carolyn, at my age, I don't think there's anything you can do to help me, but I'm here anyways, because she had gotten to the point where her bladder symptoms were so all-encompassing, she was scared to leave her house, which is very alarming, because when you start thinking about how that's going to affect your mental state, your physical decline, because you're no longer walking in the community, going downstairs, it takes a huge toll on your strength, and potentially risks for falls and things like that. So anyway, she did make it into the clinic. I don't think you can help me at my age. And within one or two appointments, she was coming back, and and she worked really hard at the stuff. She was very motivated, but her phraseology had changed to say, I cannot believe at my age that things can change this much. So it always reminds me that, it's never too late to work on any of these things, and that there's certainly all this improvement. She kind of saying, if I can do it, I really believe anybody can do it at any age. So.
Oh, that's wonderful. That's a great story. And I'll have to keep that in mind too for myself. That's great. Yeah, that's great. Well, thank you so much for taking the time to chat with us today. Again, as always, informative. And again, I'll mention that Carolyn is at Live Well in Baden, and she's also on Victoria Street. I keep forgetting the name of this, so I have to keep checking about the emotion. Thank you. That's great. Thank you so much for joining us today, Carolyn.
Okay, thank you.